Hi everyone, my name is Rich Minuski. I am doing my evidence-based practice case study on generalized anxiety disorder with acute panic attacks. To better understand generalized anxiety disorder, it's defined with the as generalized anxiety disorder involves persistent and excessive worry that interferes with daily activities. This ongoing worry and tension may be accompanied by physical symptoms such as restlessness, feeling on edge or easily fatigued, difficulty concentrating, muscle tension, or problem sleeping. Often the worries focus on everyday things such as job responsibilities, family health, or matters such as chores, car repairs, or appointments. I also included the DSM-5 criteria for generalized anxiety disorder, which is pretty much overlapping. Excessive anxiety and worry occurring more days than not for the past 6 months. Difficulty controlling worry. Three of the following behaviors are displayed: restlessness, easily fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. Worry is not a result of another mental health disorder. Anxiety impacts social, occupational, or fundamental areas of function, and disturbance is not a result of substance or alternative medical condition. So just super important that we're always assessing for substance use and screening for other etiologies for why anxiety may be presenting, rather than just assuming that the the patient's anxiety or anxious state of being is in fact a general anxiety disorder. Overviewing the pathophysiology. The pathophysiology of generalized anxiety disorder is an imbalance of genetics and brain structure. Specifically, GAD is seen to have distortions of the amygdala in how subjects process despair and misery. Many people also have genetic factors like serotonin transporter gene abnormalities and enhanced noradrenergic activity, specifically norepinephrine. Depending on the manifestation of GAD with the individual, GABA and dopamine activity is often increased, enhancing amygdala and misery despair loops. The prevalence of GAD is approximately 2.9% of all adults within the US. Panic disorders are found approximately in 2 to 3% of adults within the US currently. And why primary care plays a role. GAD is one of the most common psych disorders seen in primary care. GAD is often undertreated due to patients normalizing these symptoms. GAD is often treated with pharmacological intervention or with psychotherapy, but not always together. And I'll talk more about that later. And primary cares are often the first responders to undiagnosed GAD. And I find it really interesting that GAD is primarily impacted and deals with the amygdala, our fear control center of the brain. And it really puts in perspective the emotional, physical impacts that this diagnosis can have on patients if you have not experienced this yourself. So, overviewing acute panic attacks. A panic attack is a sudden onset of intense fear that triggers a severe physical reaction with no apparent cause or warning. Symptoms may include sweating, chest pain, rapid heart rate, dizziness, chills, shortness of breath, numbness or tingling, abdominal pain, or headache. Risk factors can include family history, major stress, traumatic events, major life changes, smoking and caffeine intake, and history of abuse. If left unaddressed, panic attacks can impact quality of life and a person's ability to function. So my case study and why I wanted to present on this specific case. This is an individual that presented complaining of, I've been feeling increasingly anxious and overwhelmed with life in general. This patient is a 27-year-old female with no previous past medical history, presenting as a new patient for evaluation of anxiety. She reports generalized and persistent worry about multiple areas of her life, including work, housing, future planning, and day-to-day responsibilities. She describes herself as frequently fidgety and restless, often anticipating worst case scenarios. This impacts her quality of sleep, and she notes always feeling tense physically. She reports episodic symptoms outside of this normal presentation in crowded social events where she feels flushed, anxious, rapid heart rate, and in a heightened state of anxiety. During these episodes, she must consciously focus on her breathing and feels concerned that she may be having panic attacks. She indicated that she Googled what her symptoms, and it came up with panic attacks. She states that she's been aware of having anxiety symptoms for years, but previously felt like she could manage them on her own. Over the past several months, her symptoms have intensified with no identified source or reason. She denies chest pain, headaches, visual changes, syncope, suicidal ideations, homicidal ideations, depressive symptoms, no prior psychiatric treatment, denies history of manic episodes, and no known drug allergies. No past medical history, no surgical history for this patient. Her social history, she is a previous alcohol drinker, but stopped because she had a poor tolerance to it. She denies any consumption of caffeine through coffee or energy drinks. She does not do any, she's pretty much sober and does not smoke, drink, or use illicit drugs. And she does report eating healthy and having exercise regularly. Her work history, she's a senior manager for a startup where she is younger than most of her team. She explains that there's high expectations and performance requirements to feel secure in her role, that and she also is responsible for letting team members go when they're not performing to expectations, and this causes her additional stress and anxiety. In addition, her home life history, she notes moving 4 times in the past 3 years due to financial insecurity and changing relationship dynamics. She currently lives alone by herself. And her no family history of psychiatric or thyroid disorders. And both of her parents are currently alive and healthy. Allergy and medications, no known drug allergies, no medications at this time. Review of symptoms that are pertinent. Patient has generalized fatigue and tension, psychiatric excessive persistent worry, restlessness, anxiousness, feeling flushed, rapid heart rate, and insomnia. And I thought important pertinent negatives, suicidal and homicidal ideations were negative, no depression, no syncope, no chest pain, and no substance use. Her vitals were normal. She has a healthy BMI. No medical records were obtained before this visit. Her examination, just highlighting some of the pertinence. Fidgeting on exam, just remembering this exam, her shoulders were hiked up, like she couldn't relax on the exam, and I did note that. Her mental status seemed fine. She didn't seem hyperly anxious on exam or anything out of the normal. Her affect was normal. No visible neck abnormality. She had no thyroid enlargement, and her neck was supple to palpation, and her eyes were normal. No exophthalmos was seen. And everything else appeared within normal limits. Screening tools obtained. Her GAD 7 was a 14, which indicated moderate severity of anxiety. Her PHQ 9 was a 6, and I will touch on that later, but that was indicating mild depression. My working diagnosis for this patient, generalized anxiety disorder, based off of this patient's presentation with chronic history of generalized anxiety and worry that worsened over the past few months. She explained that her worry is over work and home life, and that she often is concerned about worst case scenarios. Her physical manifestations of generalized fatigue, fidgeting, restlessness, and insomnia, and generalized muscle tension is congruent with this diagnosis. Patient does not ingest substances. to rule out other causes of anxiety, and she has no past medical history of thyroid concerns in the past. And her GAD7 does support this diagnosis. I also diagnosed this patient with episodic panic attacks based off of the physical distress occurring in crowded spaces where the patient feels flushed, heightened anxiety, and her heart racing, which is also important. My differential diagnoses for this patient specifically: hypothyroidism. Patient has similar symptoms that represent potential hypothyroidism. We're ordering labs on this patient: TSH, free T4, and T3. This patient does not have physical exam findings to suggest hyperthyroidism at the base visit. So pending labs to fully rule out this diagnosis. My second differential is adjustment disorder with anxiety. Patient presents with worsening anxiety symptoms over the past few months, and specific to risk identifying factors such as work and housing stressors, but does not, with adjustment disorder with anxiety, we're often looking at like a specific instance of where the patient's anxiety was worsened and heightened, and this patient could not pinpoint a specific episode, so I didn't feel like this was the main thing that would be the reason for the patient's presentation. In addition, this patient does report with certainty that she's been anxious for a long period of time, over several years, where she's noticed anxious symptoms and they just recently gotten worse. My third differential was major depressive disorder. Anxiety is often found in conjunction with depressive disorders. The patient does have insomnia, fatigue, anxiety, and restlessness that's often found in depression. However, the PHQ-9 score of 6 with this patient, when looking at the specific questions where the patient scored points, all of it really centered around generalized anxiety regarding restlessness, fidgeting, insomnia, fatigue, and difficulty concentrating based off of this questionnaire, which ruled out, and the patient also denied having any depression, suicide, homicidal ideations, or a lack of drive. The patient is very driven, just stressed about her work performance. So pending findings, which are very important regarding this case, where this patient is new to the office. So we did order CBC, CMP, A1C, lipid panel, TSH, free T4, T3, vitamin B12, and vitamin D as baseline labs for this patient. We are also requesting records from the patient's previous provider. Dr. Walko, who is my preceptor, is a great resource, who is adult gerontology nurse practitioner, but also a psychiatric mental health nurse practitioner. And these were the labs that he recommended for the baseline initiation of care to assess for potential hypothyroid, but also additionally looking at vitamin imbalances that may have actually just exacerbated underlying anxiety to account for the patient's shift in increased anxiety that she felt was tolerable in the past. And I found that very interesting, and it was a learning point for me in this case. Pharmacological intervention. This patient is treatment naive. Patient was prescribed sertraline 25 milligrams PO once a day for the first week, and then we'll increase the dosage to 50 milligrams once a day, and we'll continue that dosage as tolerated. We prescribed alprazolam 0.25 milligrams and gave her 12 doses to be used PRN for acute panic attack episodes, to use at the onset of an episode. And I go into my patient education later on. Patient was instructed by Dr. Walko to initiate treatment now, and we'll reassess if any of the labs will alter the treatment at this time. His concern was the patient's well-being and to get to establish a better state of homeostasis for this patient. Initiation of sertraline and with the short-term PRN alprazolam aligns with evidence-based recommendations for moderate GAD with episodic panic attack. So clinical guidelines, evidence-based recommendations for this patient, counseled the patient on sertraline and expected therapeutic response in 4 to 6 weeks. Recommended side effects, reviewed side effects such as nausea, headache, and insomnia. Patient was counseled ad nauseum about alprazolam to be utilized as a short-term and temporary alleviator for acute panic attacks. Reviewed risk of dependency, sedative effects, and importance of not consuming alcohol or opioids due to potential respiratory depression. We also reviewed potential of withdrawal if taken too frequently. We referred for psychotherapy. Patient was educated on potential unknown underlying cause of generalized anxiety that may be helped further with cognitive behavioral therapy. Educated patient that sertraline in combination with CBT has improved outcomes. Lifestyle counseling on the benefits of exercise, breathing techniques, yoga, music therapy, and dancing as additional ways to self-regulate the nervous system when anxious. We are going to follow up relatively early in 1 month just to assess this patient to see her overall well-being since she is treatment naive and a new patient, and to address labs. And red flag counseled for a patient including worsening mood, suicidal and homicidal ideations, elevated and euphoric mood, feelings of not needing sleep, racing thoughts, risky behaviors, confusion, and agitation. This is really to assess for any potential misdiagnosis of bipolar disorder where the patient getting an SSRI gets pushed into a manic episode. But the patient was screened for mania and did not report any history of risk there. Some questions in regards to this case that I present to the class, just based off of my own experience with this patient. In a patient with moderate GAD and panic symptoms, but no substance use history, what safeguards would you implement when prescribing short-term benzodiazepines to minimize misuse or dependence? Personally, I'm a little hesitant with benzos. My history before nursing, I was a chiropractor, and I worked a lot with pain, chronic pain, and patients that were suffering from opioid abuse and benzo abuse. I think, and dependency is another concern of mine just going into this field. So I wanted to present that into class. I'm constantly still learning and working with my resistance and concerns. And I'm really grateful for Dr. Walko to educate me with clinical experiences and wisdom from somebody that's been working in these patient populations. And number two, in the patient demonstrating minimal improvement, if the patient demonstrates minimal improvement after 6 to 8 weeks at a therapeutic SSRI dose, how would you approach next steps? Would you increase the dose? Would you change the medication? Look at possible different interventions? I'd be very curious to learn about that. Question three, what symptom change would immediately alter your management plan for outpatient follow-up to urgent psychiatric referral? This is something that I'm also curious about. Question four, how might unaddressed childhood or relational trauma contribute to the development of persistent or generalized anxiety disorder, and how should that influence our treatment planning beyond pharmacotherapy? I'm a big proponent at root etiology of why something is present in somebody that I'm treating. I think undiagnosed or unaddressed trauma is often a core result of later mental health disorders. And this is an important question to consider and ponder. And that's why we refer the patient to CBT for additional help. And here are my references. Thank you so much for listening. And I hope you find this interesting and learn something. Thank you.